I have worked with Andrew for some years now, and Andrew has led so much that actually makes all of what we've been looking at and hearing and listening to in the morning and so far as a reality. One of the examples is probably what he's going to talk about, which is how do we adopt population health in commissioning. And as we know, it's pervasive of all systems, but commissioning is a key task and a function that would really influence a population health approach to delivery of services. And I'm hoping you're going to, as you always do, catch people's attention throughout.
Thanks, Zachary. I'm not sure about that. We'll see. So I've got the graveyard slot straight after lunch where everybody's feeling a bit sleepy. I've got to compete with Mark's sartorial elegance of his waistcoat. I've then got Andy's passion that was absolutely apparent throughout everything. So, and then you go and stick that damn video up before me with a professionally produced video ahead of me, and I've got some poxy slides in my voice. So I'll try and stand still, by the way. Okay, so they are poxy slides, but that's because it's what I say rather than what's on the slides that I think is the most important bit. I thought it'd be really important to say we are all here as an ICP and as ICPs and an ICS. But there's perhaps something about bringing us back to the responsibilities of commissioners and making sure that we recognise that whether we sit in an organisation that's a commissioner, whether we sit in an organisation that's a provider, whether we sit in an organisation that sees itself as a regulator, it makes no difference. Jackie said before, we're all targeting the same thing. We're all aiming for the same thing, which is getting the best outcomes for patients. I also want to talk a little bit about that distinction between commissioners and providers within that ICS ICP platform. Also then, it wouldn't be fair for me to present anything, and I don't think I ever have presented anything without saying, hang on a minute, there are a lot of caveats to this and there are a lot of challenges that we haven't overcome. So what I would say to you is everything that went up this morning was absolutely superb and fantastic, but do not let yourself believe that that means it's all solved. Far from it. We're way off target here, way off, so there's a lot of hard work to do. And I was going to get everybody to stand up, but Andy beat me to it. So it's just really unfair to go at this time. So the reason I wanted everybody to stand up was because I wanted to show how, despite what we said in the morning about how difficult it is to get people to do things that we think are the right things for them, you all stood up. You were all compliant. So no, we might not be demographically appropriate for Lancashire, but everybody stood up and nobody knew why they were standing up. Everybody stood up first and then we did a bit of a stretch. So my take is, let's not go for the difficult things. Let's not bother ourselves with the really hard things when there's so many easy things that we can do without much effort. But let's keep tracking for the hard things as well. And I'm going to tell you a little bit about how we're facing down some of those difficulties. So, Commissioner responsibilities. This isn't an NHS England definition. This is just me saying, I think it's, first of all, determining the needs of a population and then adequately sourcing, procuring and monitoring those services that respond to those needs. And I say needs, really importantly, because it isn't desires, it isn't wishes, it isn't wants. And my sense, my first challenge to the audience is, I think there are a lot of people using our services that have less of a need and possibly not even a need that is clinically appropriate compared to those in our population that do. Why are we allowing that to happen? So my challenge to you as providers, my challenge to you as commissioners, my challenge to you as clinicians is, why are you allowing that to happen? Because we know, we keep telling ourselves, I'm the finance guy, remember, we know we've not got enough money to do all of this, so I want you to be doing the right things rather than the things that aren't adding any value. What are we doing to make sure we do that? Traditionally, we would look at health needs assessment, look at contracts, we would look at market testing, we would look at tendering and procurement, all of these, all old stuff that actually, whether we think it's old or not, some of it is legally, we're legally responsible for. So there's some of this we can't drop away. But what we could do is we could focus on getting the right contract terms. And we heard a little bit about that earlier on from some of the stuff in the States, where the contracts are to deliver particular interventions or particular outcomes rather than necessarily just a contract for treating a group of people. And my sense is, and this is again a challenge to every commissioner in the room, but not limited to commissioners, that we've done a little in increasing our attempts at getting outcomes rather than outputs. And my sense is that we need to start looking at outcomes rather than outputs. I was on a working group, can't tell you how many years ago, but a few years ago, after payment by results had come in, which is the nice little unit of price for every single piece of activity that takes place by providers. I was on a working group that was attempting to set that up for mental health. And I asked the question, why are we going for a period of care? Why don't we look for an outcome measure? Why don't we look for mental health PBR by outcomes? Sadly, we didn't get there, and we're still working on a period of care. But actually, I'm pretty sure everybody would agree that it will be much better to be encouraging people to focus on getting an outcome for everybody. Talking a little bit about ICP, ICS responsibilities from a commissioning perspective. This is the current perceived wisdom of how we want to look at segmenting that commissioning responsibility and then drawing out those individual component parts of what I put up before, which was the old style commissioning. And what you'll see in here is words that have moved on a little bit, but essentially mean the same thing. However, there's a crucial bit within there that wasn't encapsulated in the first bit of commissioning when it first came along, which is around transforming services. Now, if anybody in the room thinks that transforming a service is a commissioner responsibility, then let me disavow you of that. Transforming a service is a provider responsibility. But is it solely a provider responsibility, or is it a responsibility of everybody? So do we think a provider can do it without a commissioner? Of course not, because they're contractually bound by the terms that the commissioner sets for them. Do we think that a commissioner can do it without a provider? Well, they can think that they know what the answer is, but in reality, the people with all the answers tend to be on the provider side. They know how things work, they know how they can change things, and that's where a lot of innovation comes from. So the responsibility in terms of where we are now is very clear that this is a system responsibility rather than provider commissioner. And I would urge, I've heard several conversations, and I've had several conversations in the room with people where we're coming at it from a commissioner or a provider perspective. And if we take one thing away, Amanda's the leader, and she's a leader of an integrated care system. Not an integrated care commissioner and not an integrated care provider. Integrated care system, okay? You need to indulge me for a minute. So Dominic's gone, that's good. I won't upset Dominic. So I need this indulgence because I know, as well as everybody else in this room knows, that population health management is not the same as public health, okay? It's not the same as public health work, okay? However, and it's always going to be different. For the purposes of my next set of slides, which are some of the challenges, some of them find themselves very much embedded in a personal belief that without appropriate attention to public health and public health issues, we will not deliver population health management. So I think we've heard some of it. You can't do just bits of it, but we've heard some of it. And so please indulge me with that for the moment as I come up with some of my conundrums at the moment. So how do we switch off this old system of treating ill patients and people and helping people to manage their wellness? Well, Andy gave us a pretty good show of how you start to do that. There's some damn good stuff going on in Fleetwood in my patch, where I've got a GP who is absolutely fundamental to delivering that. But that GP, in a similar way, actually no, they couldn't be any different, could they? Andy and Mark Spencer, for those of you that know him. Mark Spencer is not a person who would at all enjoy getting up and spouting the virtues of what Andy did before. But essentially, Mark has done the same thing in Fleetwood, and what he's done is he's activated that community to do it themselves, and there are people who would never have thought about doing that themselves, and they've got up and they've got on with it. What are the things that I think get in the way of switching off the old system? I think politics gets in the way. We heard about the Burnley scenario, where every MP lost their seat when the Burnley hospital closed. So we have to get over that. We've got to get around that somehow. It's there. We need to deal with it, but it's in the way. Sadly, we're all sat in a room, but there are others not sat in the room who will sort of be thinking, what's in it for me? What's in it for my organisation? What's the risk to my organisation? And they're there all the time. We need to get over that as well. The public think we're taking something from them when we stop delivering a service. They think that. What we're not very good at is explaining to them that the reason we have to do that is because if we don't do that, we can't do something else somewhere else. We've got to get better at doing that. And whilst we think we're good at change management, we're not. We're not good. We're not quick enough. We don't fail fast. We just cling on to things that we think we know and love, when in fact they're tired, old, sad. So I did say, you know, I was already in the graveyard slot, just depressed everybody even more now. We'll get better. And another conundrum here, how do we deliver at scale but respond to personalisation? So the signs have been there for some time. Choice was put in to stimulate a marketplace. We've got lifestyle that is individually unique. It is not a group of people. You cannot say a group of people have the same lifestyle. They have similarities, but nobody lives the same life as anybody else. It's different. Everybody's unique. Personal health budgets, allowing people to take control. The first batch of personal health budgets resulted in God knows how many meetings of clinicians and managers sitting around wondering whether a child or a young adult who was 20 years old, who was in a power-assisted wheelchair, could have an iPad to assist them with their communication. Yeah, so it probably costs more than the iPad itself to do that, but we still sat around wondering whether that was the right thing to do. The clue is in the title. It's a personal health budget. It's for that person to determine what they need to make their life better. Variation, Mark's talked a lot about variation, and one of the things that's a challenge for this is understanding why that variation exists. So Right Care tells us absolutely fantastically where to look, but we have to be clear about what's creating that variation. Genomics is going to come along and give us a great way of uniquely providing a single optimised solution in health and care services for a person. And that will not be at scale, I can assure you. It will be individual. Part of this is then the digital arena. We're here because it's Healthier Lancashire and South Cumbria, and it's the digital platform. So how do we present data and evidence to support the changes to people's lifestyle, the changes to access to services that we want people to take in order to make it better? Sadly, clinical audit, if you do a survey of all the clinical audit, 99.9999% of it is all about secondary care activity, very little about public health activity. And actually, it's the public health activity that we need the evidence for to say that's what we're going to do. Do we need the evidence? Do we need evidence? Do we need evidence to say that drinking less sugary drinks will give less cavities in the future, will provide less obesity in children in the future? Do we need that evidence? It's pretty obvious, isn't it? So, but it doesn't exist in terms of a clinical audit study. The public may not look beyond their horizons. So with this, what we're talking about is what came in the previous session about somebody will have a view about how they perceive the health services are delivering something for them, and they might not look beyond their horizon. Might be 3 weeks, it might be 6 months, it might be 12 months. We don't know at this point, but we need to make sure that we know what their horizon is and allow them to see into the future. You can get an app where it can change your face into a funny face and turn you into a little weasel or a little, but can you get an app? Is there an app at the moment? It might be out there already that says if I stop drinking, how many years of life will it add? If I stop smoking, how many years of life will it add? If I exercise 3 times a week, how many years of life will it add? Okay. There is one. Great, there is one. I need it on my phone and I haven't got it. And how do we measure our successes comparably? So I think I've worked a little bit on this in the past, on QALYs, etc. I'm not sure that QALYs are applicable across a whole range of services. They try to be, but I don't know. I've worked with public health colleagues who come up with different examples of this, but I think it's really tricky to get measures of success that we can compare across different services. So we need to be able to be comfortable at saying what our successes are and why. And metrics can't measure other risks. So what you're going to get in all your stats, and this is the sad thing about life, it's unpredictable. So an RTA will limit somebody's, serious RTA might limit somebody's lifestyle and life opportunities in the future. Well, the stats aren't going to show that in the way we want it to, because that's an extreme life-changing event that happens to somebody that stats don't show. It'll only show it individually. So, what are we doing on the Fylde coast to face these challenges? We've got a product, and there are similar things out there, and we need to work collectively on doing this. We've got a product that we've been developing that Amanda's pushing, but others like, which is called Nexus. It's just a platform of all the data sources that we have, and it looks at, it's a live stream of information that's available to the system, a live stream available to front-facing clinicians, available to managers, available to MDTs, with a view dependent upon their needs. And that's just a screenshot of it. When you talk about population health management, the sort of things that we're doing are similar to what was put up from the American and Wyre example, where you've got your different long-term conditions in there, you've got where the people are registered with their GPs, how they're demographically constructed, what their age group is, etc. And as Amanda says before, what we're using this for now is to say, if you're 20 in this area and you have the following issues, you're likely to proceed along your age group, and by the time you reach 35, this is going to be your main long-term condition. By the time you reach 40, this is likely to be your main long-term condition, and these are your residual long-term conditions that you have next to you. So there's just a couple of snapshots of that on there, and I just want to leave you with the idea that I started saying that it was a bit of a depressing, thought coming up here late on in the day, but hopefully some of those challenges that I've put up, some of those discrepancies and hurdles that we have to come over, will come through in some of your group work that you've got to do now. So thank you for staying into the afternoon and listening to me, and it's back over to the group now about what we do in the group work. Thank you.